Thank you for joining today's PCC webinar, Integrating Primary and Pharmacy Care, What Works for Patients. Today you will hear from 3 different speakers on how to successfully manage and optimize patient medications in the context of primary care. Topics we will cover today are strategies for successful comprehensive medication management, innovations in pharmacy and primary care integration, and a proposed national action plan for addressing the harms of medication overload. I'm Julie Schultz. I'm serving as your moderator today. I work for Mathematica as a Senior Innovation Director. I also serve as the PCC Executive Member Liaison, along with one of my colleagues, Rob Durbin from Merck. Exciting news from PCC. You may have known us as PCC, but we've rebranded to Primary Care Collaborative, still retain person-centeredness as a core to the mission, illustrated by the new logo with patient at the center. I want to provide you with a quick PCC overview. We're a membership organization with over 60 organizations, nonprofit, multi-stakeholder organization that really serves to unify and engage a diverse group of stakeholders. We're dedicated to advancing the effective and efficient health system built on a strong foundation of primary care and the shared principles. If you're joining us today and you're not a member, I really highly recommend that you consider being an executive member. You have the opportunity to participate in workshops. Some of the workshops that have happened this past year are behavioral health integration and primary care investment. You can join in a collective voice, and there's some significant networking opportunities. You can also gain access to exclusive content. Many times over this past year, we've had representatives from CMMI leadership join us to really answer questions about the new programs they're rolling out. You also receive PCC support and leadership to effectively respond to critical issues in primary care, bringing together a wide variety of stakeholders. Right now, the PCC staff is looking at a great lineup of webinars in 2020, so stay tuned for those webinars that will be available. A couple of housekeeping items. Many of you will be wondering if the presentations and the recording will be available. They absolutely will. It may take a few days, but they'll be available on the PCC website. All lines are automatically muted. You can use the chat feature to type your questions. We have some time at the end today for some Q&A, and I'll be looking at the questions that come in and surface those that I can. We're also recording the webinar, so it will be available as I mentioned. So now, with all those housekeeping items, I will turn it over and introduce you to our fantastic set of panelists today. We have Dr. Maria Kobylinski, the chairman of Geisinger Health Systems Community Medicine. Community medicine includes 44 primary care sites throughout the entire Geisinger Health System. And if that wasn't a big enough job, Dr. Kobylinski also still is in active practice. We also have Heather Schultz, who's Director of Clinical Pharmacy Strategies at IngenioRx. She oversees the pharmacy provider collaboration team, including pharmacy metrics for value-based centered care contracts. Shannon Brownlee is joining us. She's the Senior Vice President at the Lown Institute, a nonpartisan public policy think tank and civic enterprise based in Boston. She's also the co-founder of the Right Care Alliance, a network of activists, patients, clinicians, and community leaders devoted to organizing a broad-based movement for a radically better healthcare delivery system. So with that, I'm going to turn it over to our first speaker, Dr. Maria Kobylinski.
Okay, thank you. It gives me actually great pleasure to get to talk about how our pharmacies have been integrated in primary care. We actually started working with our pharmacists over 10 years ago. We have a really active anticoagulation clinic program. And since I started here, our pharmacist group have done all of our anticoagulation work, and we've taken it 100% out of the primary care provider's hands, which has been very helpful. So when I talk about the medication therapeutic disease management program with our pharmacists, It started as just anticoagulation and has kind of spread as we've worked forward through the years and thought about what can we take off of a provider's hands so they have more time to deal and manage their panels more effectively. And so as we've grown, what we've seen is we've embedded our pharmacists directly into our primary care offices. We embed them based on panel size at the office. So a small office that has maybe 9,000 or 10,000 patients may have 1 or 1.5 pharmacists in them. Sometimes the office is even smaller than that, and they may have a pharmacist 1 or 2 days a week. We've learned to standardize their roles, and a lot of my presentation starts to show you how we made it the return on investment and cost effective both for the patients, for the offices, and for your clinics that you work with, and how we do that. We do a lot through a collaborative agreement with our pharmacists so that they can do a lot of proactive things, for example, refilling medication and doing orders for lab work that needs to be done. You can see on this slide the number of current disease processes that we manage. We do anticoagulation, they do diabetes management, hypertension, chronic pain. We have specialized pain pharmacists. COPD is a newer program we've started, tobacco cessation, and most recently we've started having them work with us with our heart failure patients. Our pharmacists during the day run their clinic day 60% office-based, where they see patients face-to-face in the office. The other 40% are their televisits. Sometimes the televisits are mainly their anticoagulation, but some of those are in person. But it makes for a nice split for the patients who don't always want to come into the office. You can see this is for all of community medicine. Our pharmacists are seeing about 24,000 patient encounters per month, and we're getting about 1,500 new referrals every month within our department. We currently have 54 pharmacists hired for us, and we have them covering at 43 different offices. You can see our panel size. Some of our providers, the pharmacists will manage about 500 to 750, and then we see others that have a 4,000 to 6,000 panel. Some of it just depends on what disease burdens they're managing and what they're going to do. And you can see on the financial part here, these are billable visits. They use E&M codes. They can bill for users for managing the insulin pumps. We have our pharmacists now doing annual wellness visits with us. And when we started, it was really just kind of a slow integration, getting providers used to it. But now almost 100% of our providers are 100% on board using our pharmacists. And when we see the metrics and the quality stuff, we know that they're doing a good job for us. Community medicine at Geisinger is divided into regions. And so we've divided our pharmacy program, MTM program, also into regions. So we have a Western region, which, if you know, Pennsylvania is out by the State College area. Central region is right around our main hospital, which is Geisinger Medical Center. And that's why you're going to see we have an increased number of pharmacists in the central region, because that's where our largest hospital is. And then the eastern region, more up in Scranton areas where those would be. You can see the different specialties that we have. So we have pharmacists that do anticoagulation and metabolic disease. We have hem-onc specialty, neurology, GI, the heart failure, and then medically complex. When you see the one that says anemia, we have one pharmacist in the central region that does all of our Procrit for us and helps us to manage that. These are two different workflows we've kind of generated through daily huddles as we've done redesign. The old way of doing referrals into MTM was to go into Epic and put in an Epic order, and you could do the anticoagulation Epic order, which says, I just need my INR adjusted, and you could fill it in, and then the pharmacist would get that referral, and they would call the patient and get them scheduled within 24 hours, and then plan their care based on what was on the referral. The newer way that we started about a year and a half ago is what we call a warm handoff. So every morning in our clinics, our patients, we meet with our providers, our nurses, our pharmacist is there, and we say, okay, on my schedule, I have 4 patients that have a hemoglobin A1C greater than 9, and my pharmacist, Jared, says, okay, I'll see Mrs. Smith at 10 o'clock, and our case manager will see Mr. Smith, and so it's nice, and I introduce the patients to Jarrett right there at the visit, and then a lot more engagement from the patients when you do it that way. But either way works, depending on if you have a pharmacist on site every day or not. The pharmacists do send a note after every visit for us and follow up, and some of the follow-ups are phone call. When I do a referral by phone, with not the warm handoff, the pharmacist will make 3 attempts to schedule the patient or talk to them. If they continue to refuse, I get a message saying the patient's refused MTM management. This is just kind of a variation on what are we doing now, what do their templates look like, so that you can know how many patients they're seeing in a day. and how they have blocks in so that we can do warm handoffs. Even if they have a full schedule, they always just say, come and get me if you have a question or anything like that. So we have two different models currently depending on which region you're in. And then you can see by next year for fiscal year 21, our goal is to standardize it completely across community medicine so that a pharmacist working in State College, if he had to, could drive down to Lewistown and see patients there right away for us. Okay. This is just a demonstration of the different panel size. So we had done it per FTE, and they were seeing initially when they were family practice 450 to 600 patients, and then our goal was to really expand the panel and use a lot more people to kind of help manage some of those. And you'll see in a later slide that we've kind of automated how we do the Coumadin clinic referrals too, which has been a lot better for the providers because we can even have a pharm tech help with those. So this is just our ROI for our cost saving, and we do bill for the anticoagulation management, the EMN code or incident 2 codes, facility fees if the pharmacist is at a hot site, AWV visits we bill for, and the smoking cessation, they do that. On the back end, what we've seen is we've really been working on ER utilization, hospital admissions, and readmissions, and that's kind of where we've seen a lot more of a shift with decreased admissions or readmissions. When our patients get discharged from the hospital, we use our MTM pharmacists to help with a more accurate med reconciliation and kind of they help with prior auths for our medications. They help with a lot of those things and kind of have more time with the patient to do some education in these situations. We've started using our pharmacists for all of our new insulin starts. They do that for us, which has been amazing. We do an initial competency before an MTM pharmacist can start working in our clinics. They do a really comprehensive training process with a lot of hands-on, making sure they've got the right skill set to interact with patients. They have a checklist and an assigned mentor, and then they have routine competency exams. So they have an initial certification, and then we do recertifications to make sure they maintain their competency in doing these educations for us. Okay. It's just an example of their clinical competency, the recertification. We do some peer reviews. They look at their competencies every year, especially as they change new guidelines and keep a close eye on what they're doing. We also pay for them to have their CE days so they can continue to do that. And we fund for them to take those courses. We work on our collaborative agreements, which we update about once a year to make sure that they can still do the same amount of things for our providers when they're working with us. When I talk about how productive they are, we've been doing, this is for our anticoagulation management, and you can see that telemanagement anticoagulation has increased over the past several months. And then in the Eastern region, we started doing some in-person anticoagulation treatment for the patients that didn't really want to just do it by phone call. And we've seen really nice improvement and engagement with our patients as we continue to do more and more of the inpatient growth. Patients like it, and the pharmacists really enjoy it. I have a pharmacist who loves doing diabetic education. I have another one who, crazy as he is, loves doing the pain management. So it's kind of a nice blend for these providers. We do track the data, and really we just make sure we have our baseline data where we go through, we see where our areas of opportunity are. We know exactly how many patients, for example, at my office, how many diabetics are out of control, which one of them are going to be able to see MTM, which one can go somewhere else. And so we follow that, we work on the interaction, and then we reassess every time we do that. And we have seen continued progression in the work we've done. This is some of our tracking metrics that you can see. In July, we did over 10,000 in-person visits with our pharmacists across the board. We have over 100,000 patients in community medicine, so they're not working with a small subset of patients. We do have a rather big panel base here. You can see, for example, for July, they did 496 anticoagulation encounters for a total of 2,000 for that month. We also turned on a refill center. So we started diverting medication refills directly to a pharmacy call center. And you can see what this is showing, that starting in July, we started diverting the anticoagulation encounters through the call center where a pharmacist can manage them there and not use the pharmacists that are in the clinics with us. This is some of our data that we track. This is down to some of my individual clinic levels on how many in-person visits they do at the site, and we do this monthly, and how many phone visits they complete. So we do keep a close eye on their productivity to make sure they're doing everything we need them to do. We look at outcome with patient satisfaction. So we do have questions on these on our Press Gainies. That's a survey we use across all of Geisinger for patient satisfaction. We track to make sure that their numbers are trending in the right direction. And the number of patients that have said we don't want MTM pharmacy is really low. And we continue to work on the ambulatory programs. And so we've started working with behavioral health and some depression pathways. And this is just, you can see their PHQ score in the lower right-hand corner. They started at 13. And after working with the pharmacists that are trained in this, their score went down to a 7. So a really nice improvement. And then now they've got 14 patients that are considered in remission for their depression skills. We've also tracked for diabetes. And I know the metrics are really small on here, but you can see that, for example, we had on one clinic 141 patients with data, and their baseline A1C was 11, and then their most recent was 8 with a 2.7 decrease in their A1C. So overall, about 2.3 point decrease in their hemoglobin A1C, which is much better than some of our other health educators that we've worked with. The other thing we've been able to use our pharmacists for is we actually changed our protocol on when you go through the flow sheet, you're going to start with metformin for diabetes, and we started increasing and made the SLG2s and the GLP-1s as second-line treatment after metformin. So we've increased the ramp-up in the patients on those medications for better control and better outcomes for our patients. And we've also, with pain management, is very effective. We use our MTM pain management pharmacists for control of pain. It's not just narcotics. We use them for gabapentin. So patients that have chronic pain that are not optimized on a regimen, we use them for that with good success. We also use them for our patients as we've been trying to wean off of chronic opioids because they've been on them for probably a reason that's really not standard of care currently. And you can see that we've really been able to decrease our opioid usage in a large number of patients. This just really further goes into our metrics, and you can see is an average of 29% reduction in patients on opioids after being in the program for 12 months, and 21% reduction in morphine equivalents at the end of 12 months also. And we had we have a lot of patients that are on the opioid benzo combination, and we've seen a 54% reduction in those patients that are still on the combination at the end of 12 months. Okay, I think that's the end of my slides. Yep. Thank you.
Thank you so much, Dr. Kobylinski. I think we have a lot of, I will just acknowledge that maybe when we get to Q&A, there were a lot of questions about the billing component, using the cooperative agreement, just to give you a little heads up that we might want to circle back to that. Though I think you shared in the presentation some of the ways you're billing, and it is under a cooperative agreement. So with that, Heather, I will turn the presentation over to you.
Great, thank you. So thanks for spending some time with us this afternoon. Before I start, just to tell you a little bit about our team at Ingenio, Julie mentioned that we partner with providers. We have a team of pharmacists that work directly with physician groups contracted with Anthem. Our provider partners are primarily PCPs, but we do support large multi-specialty practices and large health systems. Our work with provider group is focused on a few areas, developing and helping to improve workflows, and specifically pharmacist-related workflows, focused on improving adherence, reduction in cost of care, and improvement in quality by closure of care gaps. We also work directly with physicians and their electronic medical record partners to deliver information at the point of care, and we'll talk a little bit about that on our last slide. So pulling from our experience across the U.S. in the next 10 minutes or so, I want to take a few moments just to share our perspective about promoting pharmacy engagement. Many of you are likely here today because you are interested in how to integrate pharmacists, or you're aware of the value that pharmacists are bringing to the table. As this quote suggests, and many headlines sort of across the marketplace have suggested, pharmacists are expanding their roles. Maria had just indicated she's been working with pharmacists for 10 years. Anecdotally, in the managed care space, I've sat across providers in the Southeast area. We've sat across from provider groups and health systems. And I would say 6 or 7 years ago, we were not sitting across the table from pharmacists. And now more and more we are, and we think that's really encouraging. And so for the remainder of this discussion, want to just offer our perspective, but then focus on how the changing practice of pharmacy will enable you to promote pharmacist engagement within your practice group. So when we meet with physician practices, and again, primarily PCPs, a little bit multi-specialty, and a couple of health systems, we encourage the practices to look at the promoting pharmacy engagement in 4 separate categories. One, to assess pharmacist value. First, in blue, it's evaluating the government and alignment within your organization. And we're going to dive into these areas in a couple of slides. So really that's looking for opportunities to include pharmacists, not just in clinics, but in additional committees that you might not consider. Second, in red, it's focusing on integrating pharmacists within your within your support teams. Once pharmacists are added to the different committees and they're integrated into the work team and leadership is aligned, opportunities will begin to present themselves for medication management or enhancement of workflows to prove the value of pharmacists and improve patient outcomes. And so once that happens, you'll ultimately end up, and we've seen time and time again, different process improvement occur, different workflows be modified. And then finally, that brings us to making sure that the practice or the provider group is aligned and measuring outcomes. And so our first category, we dive just a bit deeper into the government and alignment. So pharmacists are oftentimes within the clinic, and it is critically important for everyone across the continuum to understand the value and role a pharmacist will play. And since we just said that it's evolving, it's really a perfect time to look at your different committees through a new lens. When we practice with partners, when we partner with our practice providers, when we see some providers' practices having the most success when they are focused on, the whole practice is focused on medication management. And so we know that alignment is just half the battle. So when the healthcare team is able to understand the value that a pharmacist plays, that's when you'll be able to derive your best practices and workflow, improvement in workflow. And at times, because it's evolving, it might not entirely be clear where a pharmacist could provide that incremental value. And that's why we encourage our provider partners to add pharmacists to non-medication related committees. And so you're probably thinking, what does that look like? So for example, if you have a transitions of care meeting and a pharmacist is not on that meeting, we encourage the practice to consider the value a pharmacist might bring. They will be able to identify best practices in medication reconciliation at discharge, but also when the member or the patient comes into the office at that discharge. Another area or avenue that we identify a pharmacist could be of value is in the business, so the managed care business team. I mentioned a few minutes ago, 5 or 6 years ago, we didn't see a pharmacist sitting across the table, and now we're starting to. And so going back to your managed care business team and asking the question, what value would a pharmacist be able to help and deliver? And oftentimes we see that when identifying opportunities and the value of closing STARS and HEDIS measures. And moving on, okay, there we go. Once the pharmacist is established on governing committees and stakeholders are aligned within your organization, that's where we've seen the real change take place. So when pharmacists engage, they are obviously collaborating with many different disciplinaries across the organization, nurses, physicians, case managers, and then clinicians like ourselves at the health plan and PBM. We've witnessed where pharmacists, when on business committees and clinical teams, able to identify multiple opportunities of clinical and cost care gap closures, And while that is very tempting to tackle those, we have seen some of our practices, especially our PCP practices, be most successful when they start small and consult the entire care team when establishing the patient population for targeted intervention. And so setting criteria for when to engage a pharmacist and which population a pharmacist should engage on is one way to ensure consistency across the practice and standardizing the team-based care approach. Okay, wrapping up here. Touching a little bit more on process improvement. So once the pharmacist is engaged and on the right committees and part of your care team, that's where you'll be able to identify opportunities to close care gaps, improve the cost of care. Many times you'll want to focus, we've seen practices focus on a few different items, but as I just mentioned, really narrowing in and getting your criteria, standardizing your criteria for engagement in your patient population. When we partner directly with those provider groups, our support is really in the effort of practice transformation. And so we accomplish this by helping the practice identify cost and quality opportunities through data and claims analysis that we have, but then also encouraging our partners and our pharmacists, if they're there within the practice, to use the EMR data combined with our claims data to provide a full picture or a full story. We have recently witnessed practices utilize, when they're utilizing the claims and EMR data and they've identified cost as a barrier to adherence, they have put into place learning sessions that have been held throughout the practice, and then also implemented an EMR workflow, which we will cover in just one slide. It was a mid-2019 program, and we expect results early in 2020. Finally, and the last sort of step or last category into implementing pharmacy engagement within the practice, we encourage everyone to start with the end in mind. When integrating a pharmacist within your practice, as I noted earlier, focusing on a targeted population, ensuring that there is consistency across the care continuum is the best place for the pharmacist to start. For the pharmacists in the audience, don't underestimate how valuable you are, but also communicate the outcomes, communicate what you have done to the care team. That will help to confirm the value you deliver, but then also enable your care partners to have that trust and relationship to continue to engage you in the different committees and the different care gap closure. So with that said, let's move to our last slide, which is our case review. So we have a small system in the Midwest that identified a medication management as a priority for their organization. There was a medical director from that organization, a pharmacist from that organization, and one of our health plan pharmacists. The goal for that organization was to add additional pharmacists to their system, and their focus their focus area was cost containment and also removal of medication adherence barrier, which was cost. So the existing pharmacists worked with our health plan to gather data about cost and adherence opportunities. They used that data to create an education campaign amongst the different specialties that were targeted within the practice. They also added edits within their EMR that would help identify when a member should be referred over to the practice, the pharmacist worklist practice, for medication counseling and or MTM counseling. The pharmacist then worked with the prescribers, and they built the business case, and they onboarded one additional pharmacist to manage the medication adherence information that was generated from the EMR alert, and they started this in mid-2019 and are expecting that they will be able to measure outcomes in early 2020. Preliminary results, though, indicate that they are identifying patients through our claims and EMR data analysis a bit faster than they would with us just sending messages to them via mail or via email or using our population health-based platform. And so that to us has really been a great experience in learning what the workflow of that particular system was, but then also helping them realize the value of pharmacists and then creating a business case to onboard additional pharmacists by utilizing the tools that they have already in place today. So I think with that, Julie, I'll hand it back over to you.
Great. Thank you so much, Heather. And I will quickly turn it over to Shannon.
Great. Thank you so much. Next slide, please. So Julie very nicely introduced the Lown Institute, so I want to tell you a little bit about myself. I'm a policy expert with just enough clinical knowledge to be dangerous. But I'm also the daughter of a 90-year-old mother, and the issue that I'm going to talk about today, which is often known as polypharmacy in the literature, is an ongoing battle, and I know it is for a lot of families and for a lot of patients, especially older patients over the age of 65. Next slide, please. Oh, no, stay here. Thanks. Sorry, back. So a little background about the terminology that you're going to see. We call polypharmacy medication overload, and that's because polypharmacy is not very well defined. Some people say polypharmacy occurs when the patient's on 5 or more drugs, some people 6 or more drugs, some people 10 or more drugs. But more than that, patients don't understand the term polypharmacy. And so as we began to think about a project, a 2-year project that we were funded to do by the Gordon and Betty Moore Foundation on the problem of polypharmacy, we realized that we needed some new terminology. So you can think of polypharmacy as a risk factor for many of the outcomes that you're looking at on this slide. But it's not necessarily causing it. A person can be on 5 appropriate drugs and be doing just fine. It's really kind of a red flag. And medication overload, in our terminology, refers to the situation when a patient is on multiple medications, one or more of which may pose a greater chance of harm than benefit. So there's no strict cutoff for the number of medications that becomes harmful or overload, but it's very clear that the greater number of medications the patient is on, the greater the likelihood of harm, including serious, even life-threatening adverse drug events. So the statistics speak for themselves. About 40% of older Americans are on 5 or more medications. It is not unusual for people to be on 10 or more and even 20 or more. My father-in-law is an example of that. 5 million older adults are seek medical attention for adverse drug events in 2018, and we estimate that there are going to be 150,000 premature deaths in the next 10 years due to adverse drug events. This is a significant problem. It's epidemic, and more important almost than what we're seeing now is what we're going to see in the future. There's been a 200% increase in polypharmacy over the last 20 years, and the trend is still going upwards and upwards and upwards. Next slide, please. So our project was started in about exactly 2 years ago in December of 2017. And we started with a report, a national report that looked at the literature and involved interviewing 50 different experts around the country. And the report really describes the scope of the problem and what the main drivers of the problem are. We released the report, Medication Overload, How the Drive to Prescribe is Harming Older Americans, in April 2019. And at the same time, we had convened a working group of 22 experts in medication use and polypharmacy to develop an action plan. This action plan is going to be released in late January next year, and the creation of this action plan was really the work of the working group and another set of experts who served as an advisory committee. And this is the in-person meeting that we had. Everybody looks pretty happy. It was a very fun and very hard process. So next slide, please. So medication overload has several drivers, but the three main ones are a culture of prescribing, information and knowledge gaps at various points along the care process, and fragmentation of care. So the culture of prescribing is really all around us. Advertisements that link prescription medications to serve happiness and health. These are direct-to-consumer ads, increased medicalization of aging, and the hurried pace of medical care, and the desire of both healthcare professionals and patients to do something have sort of fostered this expectation that there's a pill for every ill. And certainly the pharmaceutical industry has had a very important hand to play in this culture of prescribing. But there are also really significant information and knowledge gaps that also contribute to the problem. Clinicians and patients lack this information at the point of care about what drug interactions are because we simply don't know. They lack information about and skills about how to look at evidence and also how to make informed decisions regarding medications. But really importantly, for remedying the problem of medication overload, many clinicians lack deprescribing skills. It's not taught in medical school. It's not focused on in continuing medical education or during residency. And so this is a real gap in skills. And finally, fragmentation of care is a huge contributor. There's a pervasive lack of communication among a patient's various providers, as all of you well know. And prescriptions may be written to treat what appears to be a new condition, but which is, in fact, a side effect of another drug that the clinician does not necessarily know the patient is taking. So this prescribing cascade can lead to a cycle of debilitation and even death in patients. And we have talked to families where the person literally died of medication overload, not of the disease that all the medications were treating. Next slide, please. So let's move on to sort of what's next, and that's the action plan, which will be coming out in January. So we have 5 categories of recommendations. Probably the most important of which is the first one, and I'm going to go through these in a little bit of detail. So the first one is a prescription checkup. Implement prescription checkups. Now, what's a prescription checkup? So we have a lot of terminology out there describing various ways of reviewing medications. And a prescription checkup is really quite a different animal than a lot of them. Even medication therapy management and comprehensive medication management, which can often be the most complex and comprehensive. And really the most important distinction in a prescription checkup is that the goal going in is to do appropriate deprescribing. It should be an explicit goal. It requires a very close conversation with the patient. So it also requires 4 steps, and I'll go through those steps in just a moment. But it's a little bit of a different animal than the current ways of going about medication reviews. And there are ways to adapt existing medication reviews that are paid for example, medication therapy management, that may help get the widespread implementation of regular prescription checkups available to patients who need them. The second one is raising awareness about the problem of medication overload. This is a massive problem. It's really epidemic, and yet there are many, many clinicians as well as many patients who are not entirely aware of the fact that it is a problem. And so raising awareness about medication overload is really important. Number 3, we need to improve information at the point of care to avoid inappropriate prescribing and to facilitate deprescribing when necessary. And I'll talk about that in a little bit more detail. We need to educate and train health professionals to better understand the benefits and harms of medications, improve their skills in more careful prescribing, and help them learn how to deprescribe. And finally, the working group recommended that we see a reduction in industry influence. The pharmaceutical industry and biotech industries heavily influence what clinicians know and don't know about medications and indeed about diseases in general. And patients certainly are not getting balanced information. So everyone needs better information about medications. Next slide, please. So prescription checkup. As I just said, the prescription checkup is very similar to other medication reviews, but it's fundamentally different in some ways. It requires 4 steps. There's an inventory step, which is what drugs is this patient on? We might have hoped that electronic medical records would solve that problem, but they have not. Brown bag reconciliation is still a method for trying to find out what your patient is on. But this is a crucial step, and however it's done, it's the very first step that needs to be taken to know exactly all the medications and including over-the-counter drugs that the patient is taking. There is then a period of inquiry where the patient needs to be engaged in what is do they understand what the drugs are for? What are the drugs for? What's the indication? Do they have any side effects that they've recognized? Do they have any problems? How do they feel about the medications they're on? And then an intervention. And that often involves either reducing dose of many medications can certainly, the side effects of many medications can be reduced by reducing doses or by proper deprescribing. And the final step is follow-up. It's important that how patients are doing be checked on going forward. And I want to say that Geisinger, in some ways, has really kind of set up a perfect situation where prescription checkups can be done in a really effective way by having a pharmacist integrated into the primary care practice. So next slide, please. Oh, I'm sorry. I think I might have messed up. Hold on, but maybe not. This comes of not being able to do the slides myself, and I apologize for that. So why don't we talk about what clinicians can do, because I don't want to cut into our question time. So as clinicians, those of you who are clinicians, you can certainly learn about the risks of medication overload. There are many different ways to do that. You can certainly look in the literature. You can look at our report. But it's important that as many clinicians as possible really understand the risk to their patients of being on multiple drugs. There are some continuing education programs about deprescribing. There will be more coming online. The National Institutes of Health just made an award to develop a U.S. deprescribing network, which will be doing some really important work, not only doing research but also developing deprescribing guidelines for more and more different kinds of medications. These deprescribing guidelines need to be made available at the point of care, and clinicians may need to work hard to get them, but they can. And your clinical membership organizations, your specialty societies, need to update clinical practice guidelines. They're part of the problem of the information at the point of care. Guidelines often do not include when to stop medications, and they often don't include information about how to treat older, more frail patients differently than younger patients. And finally, become a pharma-free physician, clinician of any sort. The influence of pharma really is an important piece of the problem. Next slide, please. So policymakers also have a very, very important role to play, and certainly policy can happen in a number of levels. It's not just legislation, but there's also changes that can be made in coverage decisions. But we do need a public awareness campaign on a national level. to make sure that patients understand, A, that there is real danger in having multiple medications and they need to talk to their doctors about it. You know the phrase from the direct-to-consumer advertising that says, talk to your doctor if this drug is right for you. Well, they should also be saying, talk to your doctor if this drug is wrong for you. We need a patient-directed awareness campaign for various drugs, and these have been shown to be highly effective. For example, a trial conducted in Canada called the Empower trial, which simply mailed brochures to patients who were on benzodiazepines, found a significant, almost 50% reduction in the rate of patients taking benzodiazepines after they had gotten this brochure and they had gone and talked to their clinician about it. The rate of deprescribing went up when the physician also got information. So there needs to be education and awareness campaigns on both sides of the stethoscope. There also needs to be a Medicare reimbursement code for this kind of work. Doing a prescription checkup can be a lengthy process for a patient on multiple medications, and there may be ways to adapt things like the wellness visit to a prescription checkup to be able to pay for it. Next slide, please. So health facilities can certainly implement prescription checkups for patients taking multiple medications, especially nursing homes and other kinds of care facilities. There can be education campaigns for clinicians to raise their awareness. E-prescribing guidelines need to be readily available for clinicians, and institutions can become pharma-free institutions to reduce the influence of pharmaceutical industry. Next slide. And for healthcare organizations like the specialty societies, continuing education programs are going to be very, very important to help currently practicing clinicians know how to do safety prescribing. And there are a number of other possible things. I'm not going to go through all of them, but I wanted you to have them on the slides. But we also need to incorporate training on careful prescribing and deprescribing into undergraduate curricula and graduate curricula for residents and other trainees. Next slide. And finally, if you want more information, I encourage you to go to the website and you can download the report. It has many, many resources in the appendix for clinicians, for policymakers, for pharmacists, and for anybody who's interested in this issue and wants to get involved. So thanks very much.
Thank you so much, Shannon. I'm just struck by all of our presentations today. I have a clinical quality improvement background, and the phrase "make the right thing the easy thing" just really surfaced, I think, through all the presentations. And there were several questions in the chat box related to whether the slides and the presentation will be made available. Yes, they will. We'll give the PCC team a little bit of time, so probably more than likely within the next 48 hours. Both the recording, which will include the slides, so you kind of have to go into the recording and the slides will be available. I know there was a lot of rich information available in the presentation, so you will have those available to you. So before I move to some of the questions that were asked, I'll ask all of you the same question, and really just curious, from the work you do, you know, what's one thing that you would share that's been a discovery in doing this work? And also, from your perspective, what would you say maybe is the next step or the next opportunity related to integrating pharmacy care and primary care? So we'll start in the order that people presented. So I'll start with you, Maria.
Thanks. I think one of the things that we would have done differently here at Geisinger Community Medicine is even though we've been doing the anti-coag clinic with the pharmacists for many, many years, depending on which level and what providers you talk to, there was initially a lot of resistance in turning over some med management to the pharmacy team. One of the direct quotes I got from one of my providers is, "I'm going to be out of a job because the pharmacist is going to do everything for me." And learning from that, I think that struck home for how a lot of my providers were feeling as we integrated it. until they got to start working with them. And then they were like, it's such an asset to the clinic. They integrate so well. They add such another level of authority at the clinic level that we actually are saying, okay, where else can we put them? We have, you saw that we don't have ones at every single site. Every single clinic wants, I want my own pharmacist. I want my own pain pharmacist. So I think we've got a limited need, and I think looking forward, we've got to make a way to make sure it becomes standard of care for everyone in community medicine, which it slowly is becoming standard of care, and they're 100% part of our team now.
Thank you. Heather?
Hi, I think a lesson learned is, from our perspective, looking for a champion, a partner at the clinic that really identifies the value you can bring and wants to partner and help you champion that. That would be sort of our first lesson learned for integrating new pharmacists within the practice. And then I think also utilizing tools, existing tools. So integration into the EMR and delivering information at the point of care is something that we see as a future opportunity and that we plan to really partner with our providers on. So those are two areas in looking back that we would focus on.
Thank you for that. And Shannon, I know the action plan will be coming out in January, but would love to hear from you the response to this question as well.
Oh, absolutely. So actually, it has a little. It's because we did a series of focus groups to test the new terminology that we were working on, medication overload and prescription checkup. And what was really surprising was how much patients loved the idea of a prescription checkup. And this is a focus group that included, everybody from the lady in pearls living in the penthouse to the doorman down below. And they, to a person, really, really wanted to talk to their doctors about the multiple medications they were on or that a family member was on. They needed these conversations, and they knew there was something wrong with what was going on, but they had they didn't have the language to be able to open the conversation. And I think that was really instructive for us.
Thank you. Well, Maria, I gave you a heads up that there were quite a few questions about how to bill for the pharmacist. So I'm going to try and consolidate some of the questions. You indicated in the presentation that there is a collaborative agreement and training that's done, and you refresh it every year. But some of the additional questions are around, do all the insurance plans pay for the pharmacy services that you're billing for? And then a very specific question in terms of, is this incident to billing?
Great questions. Most insurances do pay for it. Now, for our Medicare patients, they have a copay, and so it's important that you know what the cost is going to be for your patients. For patients that have Geisinger insurance, we waive the copay because it's just going to be better health and better outcomes for the patient. The other thing that we've done to help is if our providers do a warm handoff to the pharmacist and the pharmacist sees them the day that they just saw the physician, that's a no-charge visit from the pharmacist to help establish that collaboration so the patient's not getting charged twice. I think that's number one. And then the pharmacists that do the diabetic education are certified to be diabetic educators, so you can bill for that time. And I think getting those other certifications so they can bill for some of those interventions. And then really, I think watching from the back side of it, if you've got your A1C under control, how much healthier is your patient panel? And so we do disease-specific huddles at our offices, and they're multidisciplinary. So for diabetes, we have our MCM pharmacist, a health manager, our head nurse, one clinician, one front office staff, and we go through the list of all our patients for the week or for the day that have out-of-control diabetes, which ones are on the schedule, who needs an outreach call saying you haven't been seen, let's get you in. And people own the process, and they say that I'm going to own that patient and help get their diabetes under control. So I think that part of the collaboration is more helpful too. Was there another part to that question? I'm sorry.
I just want to make sure the incident to billing? That you answered that in your response. Yep.
Okay.
Okay. That's I am not as familiar with that, so just wanted to clarify. And Shannon, we have a question. Brian is wondering, and I'll just go ahead and read it. To help approach CMS for reimbursement for deprescribing, have you considered submitting a CPT or current procedural terminology code application?
We have not done that specifically, but certainly that is an important step, I think, in making deprescribing something that's a normal part of clinical practice, particularly primary care practice. So thanks for that comment. And when you say we, let's follow up. And when he says we, meaning the Lown Institute, the Lown Institute's job here was to convene and to organize the thinking around this action plan, and we are now contemplating our next steps, but we're hoping that we can be involved in some of the implementation of the action plan, but certainly the U.S. Deprescribing Network could conceivably be doing some of this as well, and that might be a great one for the Deprescribing Network.
Perfect. And maybe one more question for you, Shannon. We have Laura, who's just starting her nursing career, and she's curious if through the work you've done, if there were any recommendations for nurses to be pharma-free?
Oh, yes. And pharmacists. The pharmaceutical industry has done a very good job of marketing its products, and it knows that it needs to get to all clinicians and to non-clinical pharmacists as well, and has done so. And it's important for nurses to understand that being pharm-free is a great idea for them as well. So thanks for bringing that up.
Well, with that, I think we will close out our webinar, and I want to thank all of you for just sharing your insights and the work that you're doing. It was just incredible presentation. You packed a lot of information in a very short period of time, and you did it just so amazingly effectively. Again, the slides and the webinar recording will be available on PCC's website. While there has been rebranding from Patient-Centered Primary Care Collaborative to Primary Care Collaborative, the website is still pcpcc.org. And be sure to keep on the lookout for PCC's next webinar in January on trust and equity in primary care. So again, thank you to our panelists, thanks to the PCC staff and team for making the webinar possible, and thanks to all of you who participated in your great engaging questions that you submitted into the chat room. And with that, we will close out our webinar. Thank you so much.